Good evening. Sorry to interrupt your dinner. Welcome to Workshop 2. Good evening.
Hi, everyone. We're going to get started while you chew.
Thank you. So welcome to Workshop 2, Keeping Pace in the Management of Alzheimer's Disease, Precision Strategies for Safely Utilizing Disease-Modifying Therapies in Clinical Practice. All right, happy to be here with Salloway Sha and Tammy Benzinger and a large group of facilitators who are going to help promote discussion tonight. We really appreciate everyone's participation. We hope this will be an interactive session. We think it's really, and I'm sure you'll agree, is really clinically relevant, and as practice is evolving, challenges are arising. We want to thank Peer Review and Lily for providing an educational grant, Peer Review for organizing the event. Our disclosures, we're scrolling, they're on your iPad. Are your iPads working? Raise a hand if, yeah, okay, good. Thumbs up for at least one thumb up. And if you haven't already, please complete the pre-event survey. Look out for additional follow-up polling during the presentation. Submit your questions. We'll answer them during the Q&A if there's time. And I want to give, again, a special acknowledgement and thanks to the facilitators who joined us this afternoon and then this evening to help make this program even better. And you can see their names here. Visit us at peerview.com/pace24. View the slides and practice aids now and download them after the event. Join the conversation on X. Visit pace-alz.com for additional educational activities, practice aids, and other resources on Alzheimer's disease. And we have our first polling question, so please answer this along with me. Which of the following are barriers or challenges that you experience in your practice? 1, patient workup required to select the right patients for treatment with amyloid targeting therapies. Ability to provide individualized guidance to patients about the risks and benefits of ATTs based on their specific medical and genetic risk profile. Resources and understanding of workflows needed to deliver infusion therapy and monitor for ARIA. And other treatment-related conditions, eligibility to stop therapy, how to respond when ARIA is detected. So please answer now. Okay, so about 250% of people responded, and it looks like all of these are issues that people are dealing with in their practice. Okay, our goals for this program are to augment your capacity to select appropriate patients for treatment with amyloid-lowering therapy, improve your ability to educate patients regarding the risks, benefits, goals, expectations, and delivery monitoring aspects of treatment based on the principles of shared decision-making, which is really critical. Equip you with the skills needed to monitor and manage patients being treated with ATTs to optimize the safety and efficacy. Again, we're going to start with a patient case, which some of you may have seen earlier on today. There's a little bit of additional information just to keep a patient in mind. This was a 66-year-old black woman with 16 years of education with 6 months of memory difficulty. She has medically hypertension, type 2 diabetes, arthritis, controlled on medication, normal lab work, on lisinopril, metformin, aspirin, positive family history in her mother of dementia, a MoCA score of 22, mild symptoms of depression and anxiety, mild functional difficulty, and some cortical atrophy, mostly in the mild or mild to moderate range, 2 lacunar infarcts, and she was referred for further interpretation and assessment. The level of difficulty was MCI, concern about Alzheimer's disease, and an amyloid PET was ordered. And you can see some representative images there. There was an automated celluloid read. The scan was positive, and the celluloid value was 55, which was positive for cerebral amyloidosis. Okay, we're going to be talking about integrating disease-modifying therapies for Alzheimer's into clinical practice, and Sharon is going to lead us off.
Yeah, just as a reminder from how we got to where we are today. So you may all recall in June of 2021, it was really a hallmark time where aducanumab received the accelerated approval from the FDA. And then January of 2023, lecanemab followed suit with accelerated approval. And then in July of 2023, lecanemab received full approval by the FDA, traditional approval. And then January of this year, aducanumab was discontinued. And then just a few weeks ago, I don't even know what time point we are in July, maybe it was where I think 3 or 4 weeks ago, donanemab received full approval. And just to remind ourselves, the data that led to the approval, specifically for lecanemab, the primary endpoint of the clinical trials was the CDR sum of boxes, the clinical dementia rating scale sum of boxes. I recognize many of you in the audience, so I don't need to explain it to you, but as you can see, just a reminder, the orange is the placebo group, and after 18 months of treatment, in blue, the lecanemab treatment group had less decline over time by 27%. And then we saw target engagement. So we see that it removes amyloid, much as we expect. In the orange, the placebo group, there's no change in the amyloid burden as detected by PET scan. And the treatment group with lecanemab, we see that there's a decline in the amyloid PET burden. At this time point at 18 months, there's a mean of less than 30 centiloids for the treatment group, which is a difference of about 60 centiloids. And then similarly for donanemab, and again, that primary endpoint of the CDR sum of boxes, in that treatment group, donanemab, we had less of a decline over time compared to the placebo group in orange, which is 29% slowing by week 76. Similarly, again, we see that the amyloid PET burden is unchanged in the placebo group, but in the treatment group, there is amyloid clearance reached about 76% of the patients by week 76. So as an overview of today, we're going to be talking about some patient selection, but focusing on the bottom, on the drug administration and the treatment monitoring side of things.
Okay, so patient selection is really important for successful treatment and for safety. And it starts with the evaluation of the history and memory and cognitive testing, determining whether or not the person has a mild form of cognitive impairment, either MCI or mild dementia. Increasingly, we're going to be asking primary care to help us with this because there aren't enough specialists to do this type of screening. They will need brain imaging to make sure that there's not another cause for dementia besides Alzheimer's disease, and make sure there are no safety concerns that would make them a poor candidate for treatment. And then they will need additional testing to confirm amyloid pathology and ApoE testing. And pretty much, I think that's what this slide goes through as well. And there's some, as you know, there's some changes to the standard of care. We're going to be diagnosing earlier, doing much more routine amyloid confirmation than we have been doing. That's a big step forward because of this approval. We now have access to amyloid PET. More careful review of their MRI. Testing routinely now for ApoE, especially in people who are considering for treatment with amyloid-lowering therapy, and sharing those results with the family. And then really having risk-benefit discussions with the patient and the family to see if they're, to gauge their level of interest in pursuing treatment. So the main risk factors for ARIA are the ApoE4 copy number, the dose of the amyloid-lowering drug, the presence of underlying cerebral amyloid angiopathy, and as you know, the majority of ARIA occurs early with treatment, usually during the first 6 months. This is a graph, an impressive graph actually, from aducanumab phase 3 program, showing that the frequency of ARIA-E rises dramatically with the number of ApoE4 alleles. So those with one allele have about a 36% chance of developing ARIA. Those with 2 alleles have a 66% chance of developing ARIA. This is with aducanumab, this is the highest rate of ARIA, so the rate varies across compounds, but the same proportion holds with each of the drugs based on the ApoE4 copy number. The thing to keep in mind about ARIA is really, if all ARIA was mild and transient, we probably wouldn't be having too many educational programs on it. The problem is it can become, in a small percentage of cases, about 1.5% serious and seriously symptomatic or even fatal. And so that's why we need the main factors to consider are patient selection and careful monitoring and management, and especially cases that might require emergency care, the interface with the emergency setting. So there's a question on your iPad. Please take a moment to answer about initiating treatment with an ATT.
iPad not working over there?
Oh, iPad problem? Everybody,
raise your hand, please.
Raise your hand if you're having an iPad problem.
Ooh.
Uh-oh.
Oh, no.
Okay, tech gurus. We had this earlier, so we apologize for that.
So we'll move on and see if we can get that fixed. Again, it's a CrowdStrike issue, it must be. The same joke I used earlier. Okay. All right, drug administration. So some practical tips for implementing these amyloid targeting therapies for Alzheimer's disease in the clinic. So, many of you already have been facing this, but, it's hard to have a sort of consensus of what to do because every site has their own unique challenges and barriers. So it's really kind of figuring out within your own institution or clinic about what the best ways to implement these, as well as thinking about some of the resources that are involved. Biomarker testing. We were talking about this earlier about CSF, ability, interpreting those results, nuclear medicine ability, as well as interpretation of the results from the PET scan. And then really discussing, just as Dr. Salloway had mentioned, about safety. So the ability not only to do the ApoE genotyping and potential cost, but genetic counseling related to what those results may mean for the patient and family. And if your site does not have a local infusion center, finding one close to you that you can communicate with to discuss and make sure that the results that you have from the imaging and MRI for safety are in line before the next infusion. Really educating your local physician network along with the emergency care physicians, as Dr. Salloway had just mentioned, to really be in tune with detecting ARIA. And Dr. Benziger will mention this, we need to make sure that a lot of times when someone is symptomatic in the ER, typically we get a CT scan. So making sure that we have the right protocol, including an MRI. And then finally, the financial burden is not to be ignored, because although we know that insurance may be covering these. There may be copays, not only for the drug, but the infusion cost itself, as well as the imaging, both PET and MRI, and frequent recurrent MRIs to assess for ARIA, in addition to the ApoE genotyping. So really looking at all of those will be key and in your discussions with patients and families about when and if you would initiate and which type of treatment. And this is just a sample of an order set that you may want to include. And I'm not sure if this is as a practice aid, but something that people can keep in mind so that having these infusion order sets can be helpful for facilitating those infusions. And then the thing to keep in mind about the differences between lecanemab and donanemab, now that we have both approved, I'll just start on the left with lecanemab. We know that it's every 2 weeks as an infusion. It's given as an infusion over 60 minutes, 1 hour. There's no dose titration for its 10 mg per kg for this dose. For donanemab, by comparison, it's every 4 weeks. The infusion is faster at 30 minutes, and there is a dose titration. So the first 3 doses are 700 milligrams, and then beyond the 4th infusion and beyond are 1,400 milligrams. And then that also changes the timing and frequency of the ARIA monitoring with MRI. So for lecanemab, it's suggested to have it prior to the 5th, 7th, and 14th dose, whereas donanemab is more frequent, prior to the 2nd, 3rd, 4th, and 7th dose. So those are helpful to keep in mind as you develop your protocols, particularly if you include donanemab now, and thinking about the participant burden and costs. And as a reminder, there are registries. So on the left is a cms.gov registry that's required if your patient has Medicare to get that reimbursed. And then there's the ALZNet registry, which has more information, but that can be helpful for both are really helpful in understanding real-world practices, both demographics, comorbidities, and other racial ethnic groups that may not have been included. So this post-market sort of survey would be very helpful for all of us to understand in the real practice who's getting the drug, who's getting ARIA as we have this rolled out. And the final thing to keep in mind with donanemab is that in the clinical trial for Trailblazer, the amyloid PET was done at week 24, so 6 months, week 52 at 1 year, and then week 76. And really, patients could stop therapy and convert to placebo if there is amyloid clearance as seen on PET scan. So they had the option of discontinuing or switching to placebo. And so you can see in that bottom table that the overall patients that were able to switch over at week 24, so 6 months, was 30%. And then by 1 year, it's 66%. And then by week 76, it was 76%. So it's an easy way to remember that. And essentially, that was defined as having the amyloid plaque levels below 24 centiloids on the amyloid PET scan, which is consistent with a negative amyloid PET read. So there's our main differences. There's a stopping criteria here with donanemab. And then what you can see in this graph, it's showing that the mean time in the trial to switch to placebo was just under a year at 47 weeks. And those patients continue to have a continued benefit with the treatment.
Okay, thank you so much, Sharon. So the key here really is you have a drug or a class of drugs that has a mild benefit and also has a potential substantial risk. And so, like with any treatment, we need to weigh the risk and the benefit carefully with the patient and the family together, and then it's really up to them, if they're a good candidate, to decide whether or not they want to proceed with treatment. Our job up front is to determine, do they meet the criteria for being a good candidate for treatment? And if they are, then we turn it over to them in a discussion, and they can decide if they want to move forward or not. So the goal in this, in my practice, is just to be very open and candid with them about what their risks are, what the likely benefit is. The way I explain it to patients and families is that the drug, our goal is to slow down decline in daily functioning and cognition, and that where people can remain in a milder state longer with greater independence. That's what patients and families want. And usually it doesn't have to go on. I don't get into a lot of detail about differences on the CDR, some of the boxes, or the ADAS cog, or the percent slowing. It's that staying in a milder state longer. To me, the most meaningful outcome is the change. We don't have this as a slide tonight, but it's for both lecanemab and donanemab, they showed that there was a delay in moving from a milder state of Alzheimer's on the global CDR to a more advanced stage. So from CDR 0.5 to 1 or CDR 1 to 2. And that's very meaningful, because when you go from 1 to 2, it means you need more care, and there's more burden for the family. So if they can stay in that milder state longer, that is meaningful. And so that's how I explain it. And it's very important that they have realistic expectations, because they're unlikely to get better. The family's not going to see an improvement. If they come back in 6 months and they're doing the same, or a year, that would be good. That would, especially if they're in the MCI stage, that would be a good thing. And then in the risks, we talk about a very common side effect are infusion-related reactions, so you need to be prepared for that, especially with lecanemab. There's a higher rate, and it occurs fairly frequently. It's usually mild and quite manageable and early on with treatment, but your infusion center and your team needs to be prepared to handle that. Some need pre-treatment. Most people can continue on therapy. It's usually not cause for discontinuation. The main concern is ARIA, and there can be fluid shifts in the brain, swelling in the brain, leakiness of blood vessels with small amounts of blood products coming out. And I explained that it's usually mild and transient, occurring early with therapy, but that it can be more serious and something we have to monitor for on MRI and then take the appropriate action if it does occur. This is pretty much what I just said. 75% of cases of ARIA are asymptomatic. That's why we need the MRI scan to detect them. Our goal is to keep a mild or moderate case from becoming a mild and moderate asymptomatic case from becoming a serious or severe case. And so it's very important to be attentive and careful in the monitoring. And Tammy will talk a little bit about adjustments that can be made if it's more serious radiographically or symptomatically. In the new prescribing information for donanemab, there is a mention about a patient wallet card. And I think this could be helpful for patients to carry with them, or to have a banner in their EMR stating that they're on an amyloid-lowering antibody. And so I know in some EMRs it says, please use caution when using thrombolytics. It can present like a stroke, and there's a warning sign to treating clinicians, so we avoid harm and serious harm to patients. So having an alert either as an actual physical card or in their electronic medical record, I think is a good idea. Every company has a patient assistance program. Sharon mentioned about the co-pays and the costs that might be associated. Sometimes you get quirks in insurance companies where they don't want to pay, even though it should be in their scope of coverage. And so these can be really helpful to allow access to treatment. Okay, we've got another question for you. iPads working or not? They are working now? Okay, good. Well, as long as they're working, I've got another question for you. Before we take this poll on ApoE genotyping. Now, let me just give a plug. We've been doing APO, I don't know about you, Sharon, but we've been doing ApoE genotyping in our clinic for about more than 10 years, routinely, and we've never had a problem. And disclosing the result, we don't use a genetics counselor. Our team does, the clinicians on our team do that.
And are you getting it covered?
Coverage is we've been using it, and it's gone very smoothly. Okay, how we've gotten it covered up till now has been through a research test, which is pretty cheap for us. We had an arrangement. But is Joe Hutter in the room? I think I saw Joe come in. Joe, raise your hand if you're out there. Okay, perfect. Well, No, not representing, but Joe, if you don't mind my mentioning, and his colleague, Sharon from CMS, mentioned that it was their intention to cover ApoE. Is that correct? CMS?
No comment.
Okay, anyway, I heard,
That's a no
I heard that it was the intention of CMS to cover it. Now, whether or not that's happening, I'm not sure, because people have complained to me that they're not getting, so that is a real issue, coverage for the ApoE testing. But anyway, it's possible to actually do the test and share the results with patients. Remember, these are symptomatic patients who are already experiencing cognitive decline, and you're doing amyloid testing, you're making a positive molecular confirmation about Alzheimer's disease. And hearing about ApoE, it is important because it has implications for their family, but it's very possible to do in clinical practice. Okay, now we're moving on to our first set of interactions, our small group breakout discussion about practical strategies to optimize the management of early AD with amyloid targeting therapies. And we're going to go to, it's all by table. Every table should have a facilitator.
And for those of you standing in the back, I see at least 10 seats, maybe 20 in the front rows.
Please come forward.
To participate in the conversation, we need you to have a seat at the table.
Don't run away.
You guys are divided into 3 groups. Group 1, Group 2, Group 3, with different
There's plenty
scenarios.
of seating up here, and you'll make friends, we promise.
All right.
So it's like 10 minutes.
Go.
Okay, you have 10 minutes. Did the facilitators know to
Ladies and gentlemen, your time has expired. Please begin to transition back to your main groups. You have 2 minutes.
Great. Thank you all for your discussions. We're going to ask now for moderators or facilitators from each of the groups to come up to microphones so we can have a little bit of discussion and follow-up feedback on what we heard for the cases. And I can't see any of you, but I'm going to go ahead. I'm just going to try to advance the slides. If you could change the slides for us to show the 3 case variations. So we had 3 variations of the cases here.
Thank you.
And I see someone standing up on the right. So please everyone, introduce yourself, your institution, give us the case summary, and tell us about your discussion.
Hi, everyone. Oh, can you hear me okay?
Louder.
My name is Irina Schuyler Scott. I'm here from Stanford. We're in group 3, and so we had an 87-year-old Asian American gentleman with mild dementia. He had a positive amyloid PET scan, an AD pattern of atrophy, 3 microhemorrhages and moderate white matter changes, as well as an E3 genotype. So what we talked about was that largely we think he's eligible for anti-amyloid therapy, but the only caveat is this moderate burden of white matter hyperintensity, since high Physicus scores were excluded in the clinical trials for these patients. But we did talk about his risk profile, and in particular, his 3 microhemorrhages put him at greater risk, but he doesn't have any E4 alleles that would put him at higher risk. Additionally, in the lecanemab post hoc analyses, older white men happen to benefit the most from lecanemab therapy. So because he's male, he benefits from that standpoint. Because he's at the level of a mild dementia rather than an MCI, that he may be less likely to benefit from these therapies. And we talked a lot about clearly discussing the risks, especially in light of his microhemorrhages, making sure he has a care partner, a wallet card, and also getting a detailed medication list to make sure that there are no other exclusionary details for this patient.
So go ahead. No, you go
I was
ahead.
going to say, did you guys discuss whether the age was a factor and whether that was, fit in with the treatment guidelines?
Yes, so he's 87, so that he wouldn't be excluded from treatment on the basis of his age, and take it with a huge grain of salt. But in these post hoc analyses, older patients seem to benefit, so he would be eligible.
So did your group feel that he was a good candidate?
We ultimately felt that for the most part he would be a good candidate. The only kind of point of discussion would be this moderate burden of white matter changes. If we thought that this was a mixed process or there was a vascular dementia, comorbid vascular dementia, that might preclude him from treatment.
All right, thanks. I think Dr. Raji's also in group 3. Go ahead and introduce yourself for us.
Hello, I'm Dr. Cyrus Raji. I'm the facilitator for Group 3. So actually, to add to our Stanford colleague's very excellent summary of the case, there is actually lower benefit for these drugs after age 85. And one of the kind of nuances that came up in visiting the other tables is that even if he does have a partner or support system to help him with these visits, does he, at 87, given the projected life expectancy, really want to spend time doing these regular follow-ups and visits? And how does that impact on his own perceived quality of life? And also, being of Asian background, we don't have as much data from the studies to really track whether or not the drugs are going to be the same benefit as the most commonly tested Caucasian population. And so these were some nuances that I think were apparent from talking to the other tables.
Thank you. All right, I think we're moving into to middle. Are you group 2?
Group 2, yes. Hi, Christian Lackner, neuropsychiatry at Mayo Clinic, Florida. And we had this case of a 66-year-old female with mild cognitive impairment secondary to Alzheimer's disease, receiving donanemab infusions for 12 months, stable, and asking if have amyloid plaques been cleared from her brain, and is it safe to discontinue treatment? So we had interesting discussions on this initially. If it's the 1 year, most people thought it was safe to discontinue treatment based on the studies, as where 66% or so had clearance of amyloid in the brain. But usually checking another amyloid PET scan at that time would be better to make sure that it's been cleared. We also had interesting discussions regarding people who don't have access to amyloid PET scans. So if she comes in with CSF biomarkers, and then you don't have access to check another amyloid PET scan at the end of treatment, then what do you do? And so that was also, an interesting topic that I don't think we have good answers for. So availability of resources is going to be a limitation in terms of treatment. Now, the other question that arose was, is there any benefit of continuing treatment at different dose intervals based on that disease process will continue even though amyloid has been cleared, it slows down the process, but there's some people who felt maybe there's some benefit of continuing at lower doses. I'm not sure the evidence is clear on that regard yet. And finally, one of the other questions was if this person was on lecanemab, would we do anything differently? So I think based on the lecanemab data, we would probably continue treating for the 18 months and then reassess as well.
So could I just ask a follow-up? Maybe I missed it when you gave the initial part of your report. So was the recommendation to get a follow-up PET scan?
yes, people who have a follow-up PET scan available, that was sort of the recommendation to make sure that it's cleared from the brain if you have something to compare it with. If you don't, then probably safe to discontinue at 1 year based on the evidence.
And then if it was negative, the follow-up scan was negative, was there a consensus about discontinuation versus lengthening the treatment interval?
The majority, I think, felt comfortable discontinuing, and there was also some input. Some people thought it might be of some benefit to continue, and just, trying to pose the question at what dose and what interval to maybe continue treatment.
Okay.
Yeah, very, very, very tough case. Any other group 2 perspectives before we go to group 1? All right, you said it all.
No?
Oh, no, here we go.
Andrea.
Yeah.
So our smaller table, at whom the 2 clinicians are actually from the UK, where neither of these therapies are currently available. But we ended up discussing a bit about insurance coverage, and to my knowledge, CMS has only agreed to cover a single amyloid PET scan per person per lifetime at this point. So
Well, I see a hand waving from a private citizen, but that ruling was changed once lecanemab was approved, and so that restriction has been removed.
So, thank you. So that's very helpful for my clinical management. But the other comment that we threw around was that in the absence of having any follow-up imaging, it seemed safer to continue for a full 18 months, since only 2/3 of individuals were clear at 12 months. And in the clinical trial, individuals received donanemab for 18 months up to, right? So at 18 months, it made more sense to stop or to change to a more stretched out interval for dosing.
Keep going.
Great.
Thank
All right.
you.
That's fantastic. All right. Let's see what big lineup in a bright light for group 1. I can't.
We've got some.
Wait, I have to start out by saying North Carolina in the house.
That's right. So I'm Trey Bateman. I'm a behavioral neurologist at Wake Forest in North Carolina, and we had.
Just speak really close to the mic.
All right, is this
There
better?
you go.
Yeah.
There we go. So I'm Trey Bateman. I'm a behavioral neurologist in North Carolina. We had group 1, so this was Charlotte, a 66-year-old black woman with MCI due to Alzheimer's disease, and she's amyloid PET positive. We spent a lot of time talking about the vascular findings on her MRI, and so the first question for us is she eligible? So she has on her MRI, she's got atrophy that would be consistent with AD, but she also has 2 lacunes, 3 microhemorrhages, and an area of superficial siderosis, and is ApoE44. So she would, right off the bat, not be eligible for lecanemab because of the area of superficial siderosis. In theory, she would be eligible for donanemab, but I will say that no one seemed particularly excited about the idea of moving on with treating this woman because of the degree of cerebrovascular pathology, but more pointedly, the likelihood that she has cerebral amyloid angiopathy, and so, or would likely have that. And so, while she theoretically could be treated for donanemab, I think a lot of folks were not comfortable strongly recommending that for her. The question about counseling her about the risks and benefits, I think that on one hand, she's young, she has mild symptoms with MCI, and so those all sort of generally favor benefit, but she's a woman, and so that, at least in the subgroup analysis, folks did a little bit worse, although I don't counsel people on that because I'm not entirely convinced it's appropriate based off of that subgroup analysis. And then she's got the vascular risk. And so I think that most of us would have spent quite a bit of time discussing that very thoroughly, her risk of ARIA, with E4 homozygosity and the superficial siderosis. And then we said, well, okay, let's say somebody else decided to put her on anti-amyloid therapy, since most of us probably wouldn't have. How would we help to, what strategies to mitigate the risks? I think a very thorough risk conversation, going over what to look for with ARIA and ensuring that she was, knew when to contact the clinic, when we might need to do additional monitoring. And we would likely get more MRIs than the ones recommended, at least some additional ones after that. And I'll step aside for other folks.
Well, before you step aside, thank you for that. That was a great summary and very thoughtful. It raises a number of questions for me, and I don't know how your group handled this. I mean, one is, were people in your group, well, first of all, thank you for pointing out the important issue of having patients and families contact the treating center whenever they notice anything. It's better to have more reporting than less reporting. And sometimes the first symptoms can be subtle, funny, odd, and hard to differentiate from their Alzheimer's disease or some other problem. But having a good communication is really important for detecting ARIA early, so that's really good. Was your group generally in favor of treating an E4 homozygote? I can see why your group is reluctant. Our group was also about treating this patient because of her E4 status and the cerebrovascular changes, which were on the border of being acceptable. And that combination made people very uncomfortable. Was your group open to treating an E4 homozygote with a less concerning MRI?
So we talked about that a little bit, and part of what we talked about is the range of practice. There are some groups that simply will not treat E4 homozygotes, some that do. I can speak for my own group. We do offer treatment for folks who are E4 homozygotes with less vascular disease than this usually. So I think it's a little bit of a mixed bag. I think that our table sort of reflects the practice patterns that at least I've seen in my circle.
I think the other, I don't want to take away anybody else's time, but the other issue you raise, and I think all of us probably feel the same way in group one, is how much do you allow the patient to weigh in?
Yeah.
In this case, because they're not a great candidate. As candidates go, they're really borderline at best. But so how much do you allow, the patient voice to weigh in?
So, sorry. So I'm Gwen Garden from UNC, and I just want to say that in answer to that question, we had a group of neurologists from Italy at our table, and clearly we have kind of a difference in practice between Italy and the United States in terms of how much we allow the patient to weigh in. That being said, I know there are centers, including ours, that have decided that they will not offer even lecanemab. Actually, I don't know if we've talked about donanemab for E4 homozygotes. So there are centers that do and centers that don't, and so the patient doesn't get to weigh in. Sometimes they could go to another center. So I just wanted to add a couple things from our group that were kind of a little bit of interesting. There was a lot of questions about whether or not having tau information would be helpful either to the physician or the patient to make a decision about amyloid lowering therapy. I don't think we came to any sort of consensus on that topic, but I just wanted to raise that some felt that it was important to have all potential information for the patient in order to make this kind of decision. We did talk about how the difference between the donanemab and lecanemab trials would suggest that superficial siderosis would be acceptable for donanemab but not lecanemab. But it's kind of interesting because, in the end, are we really going to do that? And I don't know what's going to happen, but I just think it's something for this group as a whole to think about. Are we really going to have different inclusion and exclusion criteria based on the kind of very specifics of each individual trial as more and more therapies come about? Then one other really interesting point from our group is when you are counseling about risk and benefit, to remember that it's also very important to involve the care partner and the family in that risk-benefit analysis, because a patient may come in very gung-ho about treatment, but if the family is not behind, if the care partner is not behind the idea, it could be just a failed endeavor anyway for getting someone to infusion and making sure that they're a good reporter of whatever symptoms they may be experiencing. And I think that's all I wanted to add.
I would just want to say that was really wonderful points. The second and last point about kind of looking at the trial inclusion for donanemab and lecanemab, the differences, that kind of goes to the group 3 with the age where 85 was the max age versus 90 in one trial versus another. So kind of thinking about the treatments as a whole, it may be hard to have some of those nuances, although we do need to have nuances in terms of protocols and MRI monitoring and things like that. And then same thing, patient and family differences is a really nice point, because there may be differences. Oftentimes I see the opposite, that the family wants treatment and the patient is sort of blasé, whatever.
I think we have a comment
Just
from a
slightly
concerned
more
citizen.
context, yes. So there was a lot of pushback, not just from a certain country or whatever, on treating this patient. If the patient persisted and said, you know what, I'm aware of that, thank you, I would like to go forward, that's where the question of, why don't we get tau, because does the effect depend on your tau level, whether you're low to intermediate, Goldilocks there, or high tau? Of course it does. And the data's in there. It's hypothesis generating, but it could be helpful. As far as some of the things that there was a comment that, what about we're going to do in the end? Subtle differences in trials and things like that. Subtle differences in a certain subpopulation. I'm going to answer that question with a question. Would very large observational data with modern techniques like instrumental variables be able to sort of parse out some of that subgroup analysis, which has never been answered for any RCT? Even the 30,000 COVID-19 trials had subpopulations where, you had those forest plots with very, very wide confidence intervals. You can't do RCTs prospectively for every subgroup. There's a lot of differences here. It's not a conclusion, can large observational data help sort of answer some of those questions?
Well, that certainly is encouragement for enrolling in registries.
Yes,
and
I was
especially,
going to say that.
and especially more detailed registries where we can collect lots of data and look at outcomes, because that's really important. Thank you, Joe. Let's move on. Tammy, take it.
All right. So we're going to go back to a quick section on lectures, and then we're going to have a few more cases and some more discussion. But we are moving now into patients on therapy and talking about ARIA, or amyloid-related imaging abnormalities. And so, overall, we're talking about the edema and the small hemorrhages. And they've had a range over variable trials in terms of what % of patients get it. But overall, the majority of patients that have ARIA were asymptomatic. And the number of cases that are symptomatic and severe is very low, so only 4%. But it's that endpoint that we're trying to avoid. And so there's a lot of detail here. I just want to say this will be in the information you can download to get to this. So one of the most important things is that the imaging that gets performed is in a manner that's consistent, so that we can accurately assess small findings. So the microhemorrhages that we're trying to count can sort of disappear depending on how you run that protocol. And the general brain protocol that you might have gotten in the past for someone with memory complaint isn't the protocol to get, and it's going to be easier on your patients if you get the right protocol to begin with, so you don't have to have them come back again. It's also really important to know what are we looking for on that MRI. So if they have underlying cerebral amyloid angiopathy with any macroscopic hemorrhage, so a centimeter or greater, they have more than 4 microhemorrhages, if they have siderosis, edema, those are all factors that might suggest a predisposing condition of CAA that might not work out well on a therapy. Also, of course, anything else that could cause a hemorrhage. The other things we always look for, like aneurysms, vascular malformations, whether they've had infarcts or hemorrhagic infarcts in the past, and how bad the white matter disease is. So those are things that need to get reported in that standard radiology report. Again, with ARIA, we have two varieties. ARIA-E is for edema, and so that's what we're looking at on these flare sequences. Sometimes it's pretty obvious, so you can see this very large area of bright signal, and it's space occupying, but sometimes it's pretty subtle, so you can have just the lack of suppression of a sulcus. They should be black on this sequence, and you suddenly see a couple that are white. And you really do need to have that scanner optimized to be able to see that. Even harder for us in radiology are these microhemorrhages. I can't see it from up here. I don't know if you can see it from back there, but there's some tiny black spots here that we're trying to count. And then similarly, there's a tiny black streak on the edge of the film here. And I know it's hard to see, but it's really hard for us too. And that's where having the standard protocol can help a lot. Now, in terms of the severity, there's a radiographic severity. It's independent of whatever their symptoms are. It's a mild and a moderate and a severe, and it has very standard cutoffs. So if you have one region less than 5 centimeters on the edema, that's mild. You get 2 regions, it becomes moderate. And then if you have any regions that are more than 10 centimeters, you move into that severe component. The microhemorrhages, this is the tricky one. Trying to find 4 versus 5 microhemorrhages, really, really hard for us. Even, I think sometimes the siderosis can be hard to detect. So again, practice aids for this, and going to those links we had earlier will take you to resources. The radiology groups, American Society of Neuroradiology has been working on this. RSNA has some efforts, ACR has some efforts, and you can get to them through the links to find these things. These are just some examples of ARIA, seeing some mild, moderate, and severe ARIA-E and H. And then this I know you can't see very well, but this is another practice aid you can get to. And the key message here for any of you that are practicing in the radiology space is, for us, so for you guys ordering the test, we need to know it's for this purpose, because we're going to run a special protocol and we're going to issue a special report. And if it's positive, we're going to call you the same way we would call you if we saw an incidental infarct or stroke coming up. So it's really important that we know it's for that reason and not just for memory complaint. And then from that point on, how the ARIA gets managed depends upon, it goes back to our neurology colleagues, into not only how severe is it on the images, but what are their symptoms. And if it's in the category of some mild symptoms, you can manage it with monitoring with an additional MRI. More moderate symptoms may have to have a pause in your therapy and may need to have additional imaging and follow-up. All right, and then finally, how do you know, if somebody's had ARIA and you pause the treatment, how do you know when to start it up again? So that edema, the bright area with the mass effect, the effusions, that needs to resolve if you had a moderate ARIA before you go back on therapy. And then again, back to this patient-centered care, that is a discussion, obviously, with the patients and their families to talk about, well, you had this consequence, what were your symptoms, what's your risk going forward? And so, again, their symptoms, their genotype, their comorbidities, all of these can factor into that plan discussion. You have a question on your iPad. Hopefully it's working. And I'm just going to keep going for the sake of timing here. Okay, and then, so what if they have severe symptoms? So anytime they have new symptoms, we really should trigger another MRI. And that MRI can be done in an outpatient setting, if you have the ability to get that MRI quickly and you have a workflow for getting the report back, I think it's really helpful if you talk to your radiology group ahead of time. I'm going to be ordering MRIs for this group. What do I do if I need this MRI urgently? What's our backdoor option? How can we avoid sending them off to an emergency department to get that management? Obviously, in the emergency department, you can get a very rapid evaluation, a full set of care. On the other hand, they could go down the wrong pathway. They might get worked up as a stroke patient, start getting CT scans that can't show these findings, could get misdiagnosed and have bad outcomes. So if you do send them to the ER, some recommendations based on what people have gone through is it's definitely helpful if you know your patient's going to the ER to contact the ER yourself and let them know what this patient's coming in for, what kind of therapy they're on, what our concern is, and that it needs to be avoid having any sort of thrombolytic therapy for these patients. Also, but they could have stroke-like symptoms. They could also have seizure-like symptoms, might be the other way that they're presenting to keep in mind. And the test we really need is the MRI. So sending them to a center that has the availability to do MRI at nights and weekends may also be important for you as you're talking to them. There are some AI tools that are out there. You may see reports like this. Some companies are coming forward with ways to detect this and quantify it and track it. So some people are using this and finding it helpful. All right, now we're going to go back to some case conferences. As we go through the cases, you guys are going to have interactive questions on your iPads, and we'll get to see those answers. And then at the end of all of the cases, we're going to be having discussion and question and answer, and we'll ask the facilitators to kind of help bring forward those questions from your tables and groups as well.
So the first case, can you hear me? First case is a 61-year-old woman with mild early onset dementia. Her MMSE is 24 out of 30. Her CDR is 0.5. Her CSF is amyloid positive with an ApoE genotype of 4-4. She has a strong family history of Alzheimer's disease and has no medical exclusions. This is her axial flare, and in the middle is the susceptibility weighted sequence. I don't see any hemosiderin there. And then the GRE T2 star, I don't see any hemosiderin there. Tammy will know better. So is this patient appropriate for treatment with an amyloid targeting therapy? Yes, no, needs more testing, or this is my favorite emoji. I'm not sure. Yeah. Uh-oh. I can't go backwards. We can only go forwards.
E44, CSF amyloid positive, normal MRI.
Yeah. 61.
Oh.
Young, yeah.
Come.
I think one slide before, if you can, was the one they wanted.
Yeah.
Yeah, with all the data. Thanks.
Please vote.
Do we see the poll?
We will. I'm sure.
So 1 is yes, 2 is no, 3 test, number 4, I'm not sure.
Ah, here we go. 70% say yes. 13 and a half, if my vision is correct, say no. 10%, almost 10% says needs more testing. And then a little over 7%, I'm not sure. All right. So let's get into it. So she's 61 as a reminder, early onset mild Alzheimer's disease dementia stage, E44. So she's relatively young. She's witnessed several family members succumb to Alzheimer's disease, and she's highly motivated to start treatment that may slow the rate of a cognitive and functional decline. So that's sort of what we were talking about a little bit. What if the patient is really asking for it, really wants it? So what are the key points to discuss with this patient about the amyloid targeting treatments? Really, I mean, what Dr. Salloway had mentioned earlier is weighing the risks and benefits based on the specific circumstances. So knowing that she's 4-4, that increases her risk for ARIA as well as symptomatic ARIA, and discussing that with the patient, making sure that she and her family understand what those risks are. And that early detection is key to minimizing further harm from ARIA, and that monitoring will be key. And I was a facilitator for my group who said, yeah, let's add more MRI monitoring if we do treat that case number 1 patient. And that she needs to be vigilant about any symptoms that may arise and immediately contacting us, her treating physicians, about those potential symptoms. And that's what you said earlier, Steve. And what other key points should we talk about? Well, talking about which specific amyloid targeting treatment may be important based on each individual patient's circumstances. So let's say she lives 2 hours away from the nearest infusion center. So the dosing schedule may be an important factor every 2 weeks versus every 4 weeks. And then the possibility of stopping treatment, like with donanemab, based on the amyloid clearance verified by the PET scan, should be discussed. And that also may be important to understand whether a nuclear facility is available. And so the patient preferred the dosing schedule of donanemab, which is once a month versus twice a month, and wanted to have the option of stopping treatment if her amyloid plaques reduced to minimal levels. Amyloid PET was ordered for baseline so that later scans could be repeated to determine when to stop treatment. So she had the amyloid PET using this new technique, MIM. Thanks for telling us about this, Dr. Benzinger, which is a new FDA-approved quantitative tool for amyloid PET. And her Centiloid score was 50, which is still positive. That tracer was florbetapir. So she had that. So when would you order the first follow-up amyloid PET? 6 months? 12 months? 18 months? I'm not sure. All right. Almost 25% say 6 months, 50% about a year, and then 15% at 18 months, and then that 10%. Would you guys agree?
That's interesting. The problem with the 6 months is that the rate of being negative is not that high.
Yeah.
So you're not going to get a big yield there. I think we're thinking about, we haven't set a definite plan, but we're thinking about 12 months.
Yeah, what do you think? What do you guys?
So our practice is all over the place on this question right now.
Yeah.
Yeah. So just for clarification, the label for this medication does not say you need to get PET scans.
Yeah, so for donanemab, it leaves it open.
Yeah.
That a clinician can choose to get a follow-up PET scan and, if negative, make adjustments to treatment, but doesn't specify.
Yeah, we haven't had a final decision at our site, but I'm leaning towards, if all things being equal and resources are available, that's the main thing. I would opt to get a 6 months, and then if they can stop, you can stop earlier, right? But maybe it's not as feasible for them to get that 6-month scan, and maybe we have to wait 12 months and the cost, right?
And we're going to hold the questions till we get to the end of we're going to do 4 cases really quickly, and then we'll get to the questions.
Oh, I need to go faster, sorry. So when should a patient being treated with donanemab get the amyloid PET? Oh, I kind of jumped the gun.
Yeah.
To evaluate the treatment response. And if the patient achieves amyloid clearance, how would you modify their treatment regimen? Stop treatment, extend the dosing interval, or something else? So one of the cases had discussed that. All right. Should we discuss that, or?
No,
I think we'll kind of leave it open because we don't know. We'll get that to the question and answer. Okay, so this is case 2. This is an 86-year-old, so not unlike the case we discussed earlier. He also has a diagnosis of mild Alzheimer's disease dementia. He has a mini-mental of 25 out of 30, clinical dementia rating 0.5. He was tested for amyloid using a blood test, and his plasma amyloid test was positive. He was ApoE33 on antiplatelet therapies, but otherwise his medications were straightforward, and there were no MRI exclusions. This is just showing you his MRI looks pretty good, some mild white matter hyperintensities, but not much happening. So is this patient an appropriate patient for testing with therapy? Yes, no, needs more testing, I'm not sure. And I think we've already seen from the discussions today, some centers would treat someone like this and some people wouldn't. And so, yeah, so we kind of have a mixture here, a yes, no. I'm guessing the needs more testing might be because of the blood test that was that baseline status for the amyloid without an LP or a PET scan. In our center, some people are going forward with blood tests. Next, I guess I've got the next slide. So in terms of the discussion, it's early, he's got mild symptoms, we've sort of talked about the age impact. His genotype is a little bit lower risk, but everybody does have a risk and needs monitoring. Obviously in the early course of therapy, you get more monitoring MRIs. And here the antiplatelet therapy is not a contraindication. And so in this case, he did come back for a monitoring MRI. And here you can see the findings are shown on the right. These are the new scans. So you can see before infusion 5 for lecanemab, he now has this new area that's showing up with some sulcal effusions and edema, less than 5 centimeters. He does have, it's very hard to see, but I promise you it's there, one new microhemorrhage in that area as well. So he's got mild ARIA-E and mild ARIA-H. At first, he thought he was asymptomatic, but then reports that he fell off a chair and felt dizzy. So what would you guys do next? Continue therapy, pause the therapy and get another MRI? Take him off therapy forever, or you're not sure? So mild radiographic ARIA with symptoms. Okay, and so most people would just suspend pause the therapy and get a follow-up, which is what happened for this patient.
Everyone knew what to do in that one.
Well, it's interesting that some 12% would discontinue.
Would stop his therapy forever.
Would discontinue permanently. So that's a very conservative approach.
Yeah. And this is just to show you the follow-up. So when he comes back in later, this is kind of what we expect to see, that the ARIA-E resolves, but that blood, the microhemorrhage, will stay there on all the subsequent scans. But since there weren't any new ones, this patient was able to resume his therapy after that. And so again, this was a shared decision-making, talking to the patient and their family. Factors would be that it was only one hemorrhage, it was a microhemorrhage, it was small. His risk is still in the ApoE33 category, and the family really, and the patient really desired to continue. And then I think we decided to skip this case just to give you guys more time.
Okay, so let's go to case 4. 65-year-old, a woman with a mild MCI, interested, comes for treatment with an amyloid-lowering treatment, has an MMSE of 28, had a positive amyloid PET scan, ApoE is 4.4, has a number of chronic medical conditions, Crohn's disease on a monoclonal antibody, CIDP, a demyelinating polyneuropathy, which has been chronic, and she's been on IVIG monthly for 10 years. On MRI has one microhemorrhage, one area of superficial siderosis, and some mild hyperintensities. So a little bit complicated, younger patient, very motivated for treatment. Next slide. Oh, I guess I have control of that slide. So same question, is this patient a good candidate for amyloid targeting therapy? Oh, wow. Okay. So the clear majority felt that she was not a good candidate. A small percentage thought she was, and about 20% or 21% thought either more testing or not sure. I don't know if we have the ration. Whoops. So I don't think we put in a rationale slide, but someone want to comment about why she's not a good candidate? Is Eric in the crowd? Eric Roberson?
Yeah.
Huh?
On the left.
Oh,
So,
okay, yeah, on the left, please.
So she's got an area, she had an area of superficial siderosis, and she's on both a monoclonal and a polyclonal antibody. So those were the things that sort of stood out to me with her.
Okay. So, oh, I didn't want to show that yet. Because as you know, in the trials, we didn't allow people with autoimmune or inflammatory conditions in the trial, so we don't have a lot of evidence. We haven't studied these folks. And also people who are on other monoclonal antibodies or other immune-based treatments. The concern would be that she could be prone to have an inflammatory reaction to the treatment. It's unknown, but that's the concern, and especially being E44. So it's a realistic concern and being careful. Well, in this case, she was lecanemab. She was very motivated, and so the patient voice is important. It shouldn't necessarily be predominant, but it is important. And so lecanemab was initiated after the third dose. She developed confusion, headache, visual disturbance, hallucinations. You can see very prominent, severe edema. It was multifocal. Here we see one area of microhemorrhage. I think there were about 10 areas of microhemorrhage that developed initially. So the lecanemab was suspended. She was treated with high doses of corticosteroids, and fortunately, she survived the episode and actually is doing well. And so the symptoms resolved over 6 weeks. The edema resolved after 10 weeks, and 10 residual microhemorrhages, 2 areas of superficial siderosis. So she comes back for her follow-up MRI, and the question is, should treatment with lecanemab be discontinued, restarted at the 10 milligram per kilogram dose, titrated up to 10 milligrams per kilogram, or not sure? Okay, so there was a clear consensus here. There already was a consensus about treatment to begin with, so not surprisingly, now there's more enthusiasm for being careful. And I think she was open-minded, but I think, I don't think she was totally aware of what the full risks were. The key, I think, here is to be really careful in patient identification. So that was the first question. So not treating her to begin with. Fortunately, she survived. She could have been one of the cases that had a more serious outcome. And then, if you do have a serious case like this one, let's say she was milder to begin with, the risks were lower to begin with, but she just had a similar reaction, then the risk of, especially being 4-4, of having an even more serious reaction the next time is high. And so it's just, we want to keep patients safe. We want to bring these treatments forward, but we really need to be careful about it so we don't have the bad outcomes. I mean, that's what's really going to hold the treatment back. Not only harm patients, but hold the treatment back and the whole field back, because with this treatment are tied all the biomarkers. And so that's what helped the treatment, that's what helped all the biomarkers move forward, is getting the treatments to advance to patients. So we have to use them carefully. Any other comments about this case?
So I think, yeah, we can open it up to all 4
Yep.
cases and comments.
In case number 1, when it's borderline and you're considering Donna, did you consider getting a tau? Changed your...
Which case number 1?
So that was hypothetical.
Oh, yeah.
61044.
So we modified some of the details since we don't have donanemab available yet. So, but yeah, getting a tau PET would be probably an important question that some people might have for someone.
Are you able to get that at your center
So
covered?
we are getting it at our center, and it has been covered. Other people are telling me they're having trouble.
Yeah. So that's the thing, is the issue of the coverage, you know. I think you were saying earlier about if we could get more data, that would be ideal, and so that would help inform us. But sometimes it's, you know, resources are limited, access is limited, and the tau PET, I think we're trying to get around that by getting it through research.
Yeah.
Well, I mean, tau PET is not yet standard of care. Physicians can order it. It may or may not be available. The nuclear medicine people may or may not, more than likely they're not familiar with reading it. They haven't really had the, you know, Tammy's in the exception, or the Mayo or other centers or Stanford where they're doing a lot of this type of imaging. But in routine clinical practice, this is certainly not the standard yet. So my feeling about it is if you have that information, that should be factored into the risk-benefit discussion with the patient. So if you knew that in that case, or any case, I would share that with the patient and talk about their likelihood of response, because they may have a more muted response or less of a chance of having a response if they're in a higher tau status.
And I think another important point about that is the information that we don't know. So what we do know from the trials, they help inform us. So we don't know a lot of the racial ethnic background, subgroup analyses, and whether or not that really translates to the individual in front of us for the risk benefit.
Hi, John Hodgson. What do you tell patients who want to switch between therapies? And if so, how long would you wait in between switching?
What would you say?
I don't know. That's what I was you guys.
Go ahead.
Yeah, I mean, one, we don't have any data about that. And so I would tell them first. The second thing that I would say is I'd have great concerns about switching from one to another because of the lack of data. Would their ARIA risk be any greater for that? So I would say we're going to have to stick with it. I'm sorry, this is what we chose, and that's what I'd like to keep. That's my personal opinion, just given the fact that there isn't data. And I'm sort of going into uncharted territory. With these therapies being so new, I want to be more conservative and safe for them.
Well, I mean, I agree. It's, again, the field's evolving. I think the question would be, what's the rationale, the reason for switching? Right now, there is a reason. For those small number of patients coming off aducanumab, that's going to be ending. Mm-hmm. And so they may want to continue therapy, and then they will have to, if they want to, then you have to switch. Again, we don't know how long, what the washout should be, but usually about 3 to 5 half-lives of the drug minimum. So a few months at a minimum washout.
See a question in the back.
Yeah, so my name's Daniel Parker. I'm from the Duke Memory Disorders Clinic, and I just wanted to speak to that. I had a patient on aducanumab who developed moderate ARIA-E. We stopped treatment, and about 9 months later started lecanemab. He did have mild ARIA-H, but he has continued on treatment, and he's doing well.
Thank you for that.
I see a question on the right.
Hi, I'm Henry Tran from Arlington, Virginia. It seems between lecanemab and donanemab that there was a higher occurrence of ARIA with donanemab. If we were to treat for an ApoE44, is there any data to guide whether we should consider lecanemab over donanemab in that situation?
Yeah, I think the real issue there, you're right. The frequency of ARIA is lower with lecanemab, so that's favorable. However, if you look at E4 homozygotes, it's still 1/3 on lecanemab. And the seriousness rate, I don't think differs between lecanemab, serious ARIA, between lecanemab and donanemab, and that's really the key parameter in terms of preventing a bad outcome. So there's not a clear-cut answer to that. I think you just have to weigh, all the patient characteristics that Sharon mentioned earlier and see what makes the most sense for that patient.
Thank you.
Trey Bateman from Wake Forest. The idea of getting repeat amyloid PET to help guide decisions to stop treatment is very appealing. One of the challenges that we're having, and I think this is going to be region and Medicare region specific, we're probably losing as an institution somewhere between $1,400 and $3,000 for every amyloid PET because I forget, it's either they'll pay for the tracer and not the scan, or the scan and not the tracer, or some other asinine decision that was made. But we lose money every time that we do a PET scan. So we've shifted to doing some CSF, et cetera. It's going to be a very hard sell to then ask the institution, would you please lose some more money to make this decision? Is there any data that's going to be coming forward to help us with plasma levels that will correlate with treatment stopping decisions like we saw with the amyloid PETs? Because I think that's going to be the only way for some of us to reasonably start making that decision. I don't think some centers are going to be able to get the amyloid PETs repeated enough.
Well, we're sorry for your pain. No, honestly, I mean, that's a real life, all these things are real, touch points here that are difficult, pain points that are difficult. My feeling is there will be plasma assays to guide us in the future, given the rapidity of the advances we've made so far to get to this point with plasma and what's coming on with tau PET and so forth, tau biomarkers. But we're not there yet. I mean, p-tau 217 goes down with amyloid-lowering therapy usually, and to a certain degree, but not enough that correlate. You can say, oh, they're now amyloid negative. We don't really have that benchmark yet, and maybe we will have a panel of biomarkers. I would say, if all goes well, 2 to 3 years from now.
And that's why the registries are helpful, so that we can correlate and
Yeah.
other cohorts that are studying this. But I think it's a really important point because the resources are limited. I mean, in an ideal world, we're getting all the tests that inform us. And that's why understanding, hey, 76% of patients at 76 weeks had that amyloid reduction to negative. So maybe if we can't order that repeat scan, we're just going to treat you to 18 months or 76 weeks.
But I think it behooves all of us to really try to accelerate this process so that we can get to that point. We can get surrogates to help guide treatment that are cost-effective and more widely available. Yes?
Hi, thanks for a wonderful presentation. Paul Yates from Austin Health in Melbourne, Australia. A question possibly for Tammy, but anyone's welcome. It's about the MRIs for screening for eligibility and what was used in the trials versus what's being recommended now for looking for microbleeds. So I see that in some of the slides it's sort of T2 star, gradient recall, echo, or susceptibility weighted imaging, but the sensitivity for detection is potentially quite different between those. And so if we're going to use an arbitrary number that's the same for both sequences, is there a risk that we're going to over or under include people?
Yeah, so that is a fantastic question. And I'm going to give you the answer that's the guideline coming from the American Society for Neuroradiology right now, and what their recommendation is. That is to get the best possible scan you can for that baseline, because you really want to be able to identify what might be in the future for that patient ahead of time. So for a lot of practices, that means their 3T scan, and it means both a GRE and an SWI. Now, what the ASNR did was a project over the last year working with Siemens and Philips and GE to make harmonized protocols for all of the scanners that they support right now that you can actually just download. So links to the vendors, you could download it, and that way you're going to run the same protocol for that patient even if you switch vendors or field strengths, and that's to really attempt to harmonize it. So that's one thing. The second thing is, what do you do if there's a discrepancy in the counts between what you see on SWI versus GRE? So you saw in the examples we showed you, I'm always giving you both, and that's because at our institution, we actually have decided they're relatively short sequences, and we're just going to run both on everybody because that's going to really help us to understand it. And if in our radiology reports, what we're reporting is what we think is the real number of microhemorrhages. So if I see 10 of them on SWI, we're going to report it as 10. But if only 2 of them are on GRE, I'm going to put that in parentheses and make that comment, and then I'm going to send a chat message back to the neurologist trying to explain what this means and why it has this weird feature. And then, at our center, we're not using strict arbitrary cutoffs, so it's not that much of a problem. It's really based on this patient-centered decision-making, and that helps inform that patient in terms of what their risk might be. But it's another unknown. But that's how we're dealing with it.
Thank you. That's great. I have a second question, if I can, if no one else is...
Make it quick, because we're right at the end of time.
How fast is a fast MRI? When I mentioned to our radiology colleagues, if someone came in with symptoms that they'd need to have an MRI in emergency instead of a CT, they said, you mean within a week? And our ED colleague in the chat was balking at that.
So the monitoring protocols, if you go to those links and get them, 10 minutes on any of those scanners. We'll give you the non-contrast MRI for monitoring. We only need 3 sequences. We need the flare, and we need a diffusion, and we need some sort of blood-sensitive sequence. And so that, on all of these vendors, is going to be 10 minutes or less, which means they really can slip it in. But it's helpful to have that conversation ahead of time. This is kind of getting into nuts and bolts, but one thing we did to help with that is we made a specific order for it when we talk about order sets that helps it get expedited so they know, oh no, I don't need an hour for this patient.
Thank you.
Okay. So key takeaways are ATT's an exciting advance in care. There are many complexities in patient selection and delivery. We're all, working on integrating them into clinical practice. Shared decision-making is foundational here, and just really careful safety monitoring is really the guide, it should be guiding us. You can visit us at peerview.com/PACE24, complete and submit your post-test and evaluation for credit, download the slides, and practice aids. Watch the online activity in the coming weeks. For those of you who are ARIA junkies, there's going to be a double session on ARIA sponsored by the association on Wednesday morning. There'll be a session on mechanisms with a great faculty. Tammy and I will be coming back with others in the afternoon with a team with some stroke neurologists as well, and discussing some even more different cases and some more serious emergency type cases, which I think are going to be really worthwhile. So that's on Wednesday morning and Wednesday afternoon. And I think, is that it?
And we just want to say,
I
was going to say, just thank you to all of you for your participation and feedback, and for the facilitators who were here.
Thank you, facilitators. We really appreciate it. And to all of you.
And, we're learning from you, I think, as much as you're learning from us. So I really appreciate all the participation tonight. Thank you.
Thank you.
All right.
Oh, there's water here?
Yeah.
I've been thirsty.